So how does a cardiologist treat blood pressure in 2024 and beyond? What are the modern day therapeutics? What order do we use them in? What has the most potent blood pressure lowering effects? And what are the rare circumstances and some of the rare medications that we use in the more resistant cases? If you don't know me, I'm Dr. Allo. I'm a double board certified cardiologist. You can click on my links and find all my stuff. So when somebody comes in with blood pressure, you want to make sure, first of all, they do have a blood pressure problem. You've checked it on more than one occasion. You've compared it to some of their home readings or some of their other readings at their other physicians or primary care practitioners' offices. And you want to confirm that they actually do have a blood pressure problem. Because a lot of times the patient comes in, one time it's elevated, the other times it's not. So if that is the case and you've confirmed they do have a blood pressure problem, the first thing you want to do is make sure they don't have secondary causes of hypertension. You know, we have primary hypertension, or what we call essential hypertension, which is just a genetic hypertension. You want to make sure they don't have something else that is actually causing it. The most common cause of this right now, the most common cause of secondary hypertension is sleep apnea right now, which for most people, they are usually overweight. Now, I'm not saying don't treat the blood pressure in the meantime while the patient works on these things, but make sure that the patient is working on these things. A lot of times, once you tell them, hey, we need to go on medications for blood pressure or diabetes or what have you, a lot of times the patient is like a wake-up call for them, like, oh my God, I got to get on blood medications. I better do something. So obesity right now is one of the major causes of secondary hypertension. Obesity obviously is another one. They can work on both of those things simultaneously. Another one is something we call pheochromocytoma. You order serum-free metanephrines. It's 97% sensitive and specific for a pheochromocytoma, which is a tumor which releases adrenaline and catecholamines. And that is something that raises your blood pressure. You want to make sure they don't have renal vascular hypertension. They don't have like plugged up renal arteries or, you know, that fibromuscular, dystrophy in, not fibromuscular dystrophy, the young females under the age of 40 usually have like this fibrotic tissue in the renal arteries that go into their renals. You want to make sure, obviously, like we said, sleep apnea. You want to check all like the thyroid hormonal stuff. But in the meantime, they need to be working on those things. They do need to be treated. So where do we start with treatment? That's what we're going to dig into right now. So generally speaking, you want to start with medications that complement some of the other conditions they have. Like somebody who has coronary artery disease, you might want to start with the type of beta blockers that can reduce and help with coronary artery disease. Same thing with heart failure. Same thing with diabetes. Same thing with, BPH. If they have BPH, you want to start with one of the alpha blockers maybe. But anyways, let's get to it. So somebody comes in with blood pressure. They have nothing else. They're not hypertensive, young, healthy, eat normal diet. They're not over consuming salt. They're not doing any of the crazy stuff that we would normally look at. And for the most part, they're doing everything right. Where do you start? So for me personally, I usually start with lisinopril. Lisinopril is an ACE inhibitor. ACE inhibitors, for you guys that don't know, come from viper venom. That's right, viper venom. That's where ACE inhibitors come from. That's how we discovered it. A viper would bite you, inject a bunch of viper venom into you, and your blood pressure would get so low that you would not perfuse your organs anymore. No more blood flow to your heart, lungs, brain, kidneys, what have you, and you would ultimately die. Now, the one I start with is lisinopril. There are some side effects. Some people get this dry hacking cough. And if they get that, we usually will switch them to something called losartan. Losartan and lisinopril are easy to switch up. We usually can start with 10 of lisinopril, for example, which is about 25 of losartan. 20 is about 50, 40 is about 100, and so on and so forth. You can start with slightly lower doses of lisinopril. The reason I start with lisinopril is, first of all, it's the most tried and true. It's been the most tested, has the most data, and it has the most potent blood pressure lowering effects if you use it as a single agent. If you use it as a single agent by itself, gives you the most bang for your buck. These are all mostly generic, so you don't have to worry about it. That's where I would start. Now, there is a serious side effect called angioedema, where patients get like puffy lips, swollen tongue, maybe difficulty breathing. That's the end of ACE inhibitors for that patient. You cannot use them. I've rarely seen that, in, let's say, I'm like over 20 years of doing medicine. I would say I've probably never seen that in my patient. But of course, I don't work in an ER. And those would probably land in the emergency room more than anything. But of all my patients, I've almost never had any of them say, I get angioedema or I got angioedema when you started me on this medication. So definitely super rare. A lot of people like to claim that we should treat African Americans and Caucasians and Asians differently based on science. That is old science. If you look at the newest guidelines and the newest statements from the American Heart Association and the American College of Cardiology, all patients respond the same to most classes of medications. It's just that we used to ignore African Americans and we used to ignore the things that they said, and that's why we didn't treat them properly. So that's where I would start. Now, if a patient has the cough or something else, I would switch to an ARB or an angiotensin receptor blocker instead of an ACE inhibitor. The ARB would be something like losartan, telmisartan, valsartan, etc. I usually go with losartan because it's the easiest, also quite potent. Now, what can you add on? I usually don't like to start with thiazide diuretics. The most common ones are like hydrochlorothiazide, chlorothalidone, and dapamide. People think these are diuretics. They are not actually diuretics. The first 2 or 3 days, they act a little bit like a diuretic. You'll have some diuretic effect, but after that, they're basically vasodilators, and especially in dapamide. But the rest of them do that as well. Most people will lose a little bit and pee a little bit more the first 2 or 3 days, maybe 4 days when they get put on it. When you combine a hydrochlorothiazide with losartan or lisinopril, you get a 30 to maybe even 60 sometimes drop in a person's blood pressure. We try to avoid thiazide diuretics in the elderly because they do cause a lot of hyponatremia, and that can cause like a lot of, strange dementia-like cognitive functional decline. So we try to avoid it in the elderly. Thiazide diuretics are also a little bit diabetogenic, which means they can slightly push you over into a little bit more insulin resistance if you have that to begin with. Same thing with the next class of medications, which we'll be talking about, which are beta blockers. Beta blockers affect something called dromotropy, lusitropy, chronotropy, and inotropy. I've gone over this in a different lecture. Look up my beta blocker lecture. Not all beta blockers are created equal. Not all of them lower your blood pressure. For example, metoprolol and atenolol do not touch your blood pressure at all, other than a very roundabout way. They generally lower your heart rate, which in some cases and in some people can reduce your blood pressure. Almost all of the other ones, propranolol, carvedilol, nebivolol, bisoprolol, labetalol, almost all the other olols that you can think of do have some alpha blockade and can lower your blood pressure directly by alpha blockade, which dilates out your arteries, whereas beta blockers mainly affect the beta-1 receptors, especially metoprolol and atenolol, which will only slow your heart down. Because cardiac output is stroke volume, the amount of blood squeezed out times your heart rate. If you lower the heart rate, you can reduce stroke volume a little, but that doesn't generally reduce the blood pressure overall. You do need some kind of alpha blocker. The alpha blockers are like terazosin, prazosin, things like that. Those are directly alpha blockers, and they will lower your blood pressure pretty much directly. Carvedilol has some of that action and some of the other beta blockers, but not atenolol and metoprolol. We generally don't use those, but they can be used in somebody who has, benign prostatic hypertrophy. You have an enlarged prostate. This would be a fantastic choice because it helps both problems. If somebody has coronary artery disease, like plugged up arteries in their heart, a beta blocker is a good option. So carvedilol would be a good option. Now, the one thing I don't like to use is a non-selective beta blocker like carvedilol, and then because you can't control blood pressure and heart rate independently. So if I put somebody on lisinopril and metoprolol, I can lower their heart rate alone with the metoprolol if I need to lower their heart rate, and I can lower their blood pressure independently of that with the lisinopril dosing so that it doesn't affect their heart rate. But with carvedilol, for example, you're going to be attacking both. Same thing with labetalol. We generally don't use labetalol other than maybe in pregnancy, but most of these are, the beta blockers are safe in pregnancy. ACE inhibitors, ARBs are not. One thing that's neat to know is that ACE inhibitors, regardless of anything else, people on ACE inhibitors live longer. But also we know people with lower blood pressure live longer. Do you know the targets for blood pressure? Probably should mention that. 115/75 for the longest time. That is the target. That is the optimal blood pressure. You want to be at 115/75. For every 20/10 higher than that, the rate of stroke doubles. So if you take 115, add 20, that's 135/85. Your rate of stroke is twice as much. You go 155, it's 4 times as much. You go 175, that's 8 times. You go 195, that's 16 times higher rates of stroke. So blood pressure is hugely important when it comes to dementia, vascular dementia, and stroke. Make sure you remember that. The goal, now our elderly, we don't want to reduce them that much. Sometimes we want to maybe keep them a little higher because they have less compliant arteries, and the blood pressure readings that we are doing in the office are not that accurate. So you do not want to drive down elderly's blood pressure too much. They will let you know they're getting lightheaded and dizzy and they don't feel right, or they have some mild cognitive decline. You'll know that their blood pressure is just a little bit too low and you might want to cut back or take them off some of their blood pressure meds. Now, let's say you've got somebody on an ACE inhibitor or an ARB. You generally don't want to use the two together. You've got them on a little bit of carvedilol, hydrochlorothiazide. Let's say those are working, but the patient's still very resistant. What do you do next? Obviously, you've tested for pheochromocytomas, the plugged up renal arteries, the hormones, all that stuff, tumors, adrenal tumors, whatever. You haven't found anything. You just need to keep going and get them down. Well, here you can add the calcium channel blockers. Now, there are two types of calcium channel blockers. There are the dihydroperidones and the non-dihydroperidones. The non-dihydroperidones are like diltiazem and verapamil. These are basically AV nodal blocking agents like metoprolol, atenolol. They just slow your heart down. They don't really have a huge effect on blood pressure. The dihydroperidones are like your nifedipine, nicardipine, amlodipine, blah, blah, blapine. Everything that ends with a pine is a dihydroperidone. Those are basically vasodilators as well. They act almost basically like alpha blockers. They're vasodilators. They lower your pressure. Here we could add something like amlodipine. The reason I like amlodipine, either 2.5, 5, or 10, is because it's once a day dosing and you're getting the maximum effect. So I like using that one. Another one you could use is another vasodilator called hydralazine. The nice thing about hydralazine is it doesn't affect your kidney function. A lot of times you have patients with, creatinines of 2.0, GFRs of 30, 60, what have you, less than that even. You don't want to affect their kidney function. ACE and ARB is not an option. Here you could use hydralazine, amlodipine. Those are kind of your options if somebody has kidney failure. Now, what if somebody has just slightly worsened kidney function and they're diabetic? Absolutely, ACE inhibitors are indicated because not only are you protecting their kidneys from the manifestations of uncontrolled diabetes or terrible diabetes, because ACE inhibitors do that, you are helping get their blood pressure down. Using your medication is pretty potent, even at pretty low doses. So that's that. People with heart failure need to be on metoprolol succinate, which mainly lowers your heart rate, and or carvedilol. Those are the two that are proven. I think bisoprolol too, but no one really uses that. It's not really very common or available, but you could. It is in the guidelines. That is another option. So let's say we've done all of that and we are still having issues with blood pressure. What would be our next option? Another option is minoxidil. There is a medication called minoxidil, which is a very potent blood pressure medication. It's a very potent vasodilator, has very potent vasodilatory effects, and we can use that one starting at like 2.5, 5, and 10, once a day, twice a day, multiple times a day. One thing that's neat about minoxidil is it can cause hair growth. In fact, it's the active ingredient in Rogaine. Rogaine, the scalp lotion or hair shampoo or whatever it is. Minoxidil is that medication. One of its side effects is that. So women generally don't like it, but men might. So you could use minoxidil. Another class of medications is these aldosterone antagonists. These are like your eplerenone, spironolactone. Usually we start with spironolactone. The problem with spironolactone, it's usually 25, 50, or 100 a day. Especially patients with heart failure, they need to be on that class of medications. We usually put everyone on spironolactone because it's the oldest, it's been around the longest, but men may get gynecomastia. It is a little bit of a testosterone inhibitor and blocker. Men don't like that. So in those scenarios, we would switch them to eplerenone. Eplerenone is also like 25, 50, 100 a day. That scenario, men don't mind it as much because it does not block testosterone. Those are the most common ways to treat blood pressure in today's world. Am I missing a few? Possibly, but I think I've covered everything. Definitely, most of these patients could benefit from weight loss. If they're not on a weight loss medication or are not seeing an obesity specialist like myself or someone else, please make sure they are. We have so many fantastic medications now that can help with weight loss, which is one of the main causes of difficult to control hypertension. So if you treat the patient as a whole and just not just as a number, You will be better off, the patient will be better off, and everybody will be happy. If you like stuff like this, share it with all your friends, and I'll see you in the next episode.